requiring 3 or 4 units, and each unit in my billing system is every 15 minutes. And you have to determine what is in your area is an appropriate amount for a 15-minute treatment. Most of the patients that I see require between 1 and 4 units. Occasionally I'll run into 5 if I have a particularly difficult patient, particularly if it's a fibromyalgia patient, because they often take the most time and they have the greatest number of trigger points. However, again, the blue plan in our area, which is called Care First, is always the last carrier to begin paying for any particular treatment, particularly if it's new. And they will often fight to the last to avoid paying for any particular treatments. Aetna clearly has been the easiest one to get along with here in my area. Another question that has come up again that people are frequently asking, and almost every webinar they ask it, is actually twofold. How long does it take to inactivate a trigger point, and how long does the relief last? Obviously, with these case histories, you want to know how long the patients got relief. It can be anywhere from a few hours to several days or several weeks even. It depends entirely on the patient. The case history with the patient with the carpal tunnel and the numb feet, her numbness in the feet disappeared on the first treatment and remained that way even after she had had several weeks of not coming in for treatment because she developed a case of the flu and was really not able to come in for treatment, nor did we want her to come in. In that particular case, the numbness stayed away completely and was gone after the one treatment. Her wrist pain flared up a bit after her flu and is now calming down and is almost gone after 3 treatments. So she is actually a poster child for the best kind of treatment. For use of the low-power laser. We have another question that is, if you've inactivated the trigger point, but the patient is still having the referred pain, what would be your next step? What you would think at that point is that the trigger point which you inactivated is clearly not the trigger point which is creating the referred pain. The trigger point that is making up the referred pain may be a ½ inch away from the one which you treated. And that's how precise these trigger points are. So if you have in fact have inactivated a trigger point, but the patient is still having the referred pain, you've clearly not inactivated the trigger point which is creating the referred pain. And you just have to accept that and don't let your ego get involved and just go to the next nearest trigger point which is consistent with the referral pattern and look there for a continued activated trigger point. And it may be a latent trigger point which is there, and you have to just palpate it, and frequently palpating it 2 or 3 times will change a latent trigger point into an active trigger point. The difference between the two is that an active trigger point, the patient can point to that trigger point and say, that's where I hurt. And they may or may not describe the referred pain. With a latent trigger point, the patient will not be aware that they actually have a trigger point at that site, but they may tell you and complain about, in terms of their presenting complaint, the referred pain and the fact that their muscle feels tight. And by the report that the patient has given you as to what they feel, you then go back to an area where the trigger point that normally refers into that area is present, and palpate that. And palpating a couple of times will activate a latent trigger point, and the patient will say, yes, that's the pain that I feel. So these are very precise. You have a trigger point that gives you a pattern of referred pain that is rarely that different from other people who have the same trigger point and complaining of the same pain, unless there are other trigger points that come in and muddy the waters. So you have to, it's like peeling away the layers of an onion. You sometimes have to inactivate a trigger point after trigger point after trigger point until you can come to the underlying problem that the patient is presented with. I hope that's answered the question that you had. Any other questions? Okay, I think we've gone through the question and answer period. Our slide is not moving for some reason. In any case, what you need to do is, if you have any further questions that you'd like me to answer, you can send a copy of the that question to Dr. Filner at myml830.com. And that question will get to me, and I will answer it as quickly as I can. There's also a phone number which you can use if you don't feel like you want to put the question in an email, and that phone number is 1-888-789-0745. And they will pass that question on to me, and I will try to answer it as quickly as possible. There are also available, if you really, if you have been using your ML830 as opposed to having not purchased one at the present time, there are possibilities of getting further information and further training from me here in Rockville, or we can arrange to do some proctorship perhaps over the phone or over the internet. In any case, if you're interested in any of these kinds of things, just contact me at that website or at the phone number which I gave to you. Thank you very much for attending today, and we'll be setting up further webinars with more advanced treatments as well as more advanced approaches to treating various conditions